My name is Bob Rowley. I am a practicing physician. I've been practicing forever, it seems. I've been in the EHR space for quite a while. Created 2 of them. The second one actually has done rather well, which was Practice Fusion. Left Practice Fusion in 2012 and have been, I sort of have that entrepreneurial bug in me and started up another company, co-founded a company called Flow Health, which builds one of the frustrations that I have with EHR data is that they are hospital and physician-centric silos of data that don't talk to each other very well. And the best that we can do is to have a very large integrated system with a very large single instance of an EHR, but that still is, it's a bigger silo, but it's still a silo. So I wanted to build something that created a patient-centered longitudinal health record that was able to import everything from every source. EHRs, health plan data, patient-entered data, device data, and put it into one place that could be mashed together, pulled together, created in an open API way that encouraged developers to create apps around it, and create a few apps that made that meaningful. So it's a huge vision. It's an extremely challenging project. We've actually built the framework now. We're starting to populate that with some very substantial data inputs. We have 3 apps built on the platform currently: physician-facing, patient-facing, and a patient check-in app that are all feeding off of this universal data. That's my passion currently. Is sort of I don't think that HIEs are enough. I think that still leaves data in their silos, even though you can find records back and forth. But it still is. It's not where we need to get to, which is data that's outside of the EHR, is data that is universal and usable by everyone. So that's it in a nutshell.
Great. Juliet?
I'm Juliet Oberding. I'm the co-founder of Predictably Well, and we forecast symptom flare-ups and general wellness in people with chronic disease. Our particular area of focus initially is rheumatoid arthritis. So I'm pretty fascinated about this because I am a rheumatoid arthritis patient, and I took my experience in working with an expert in artificial intelligence and machine learning, looking to see how is it possible that I would be able to accurately forecast my symptom flare-ups in rheumatoid arthritis. So my interest in data is, how does data benefit the patient? So it's the patient's data. How does it benefit the patient? We see lots of apps and companies that are focused on doctors, focused on clinicians, hospitals, insurance companies, pharma, but how can we focus directly on patients and helping them to live with their chronic disease?
I'm Manny Hernandez. I'm a practicing diabetes patient. And in case it's not obvious, we were very intentional just a moment ago in sitting the 2 patients at the center, as a team. So in 2002, I was diagnosed with diabetes, and a few years later, along with my wife, I co-founded the Diabetes Hands Foundation, which you may know through some of the programs, most importantly, Tudiabetes, like essentially with a goal to connect people touched by diabetes, trying to make sure that no one with diabetes feels alone. I was doing that until April of this year, and since May, I joined a startup in the peninsula called Lebongo Health, which is trying to address a lot of the pain points that make diabetes care, largely inefficient, and lacking the patient at the center. So, for example, when you test your blood sugar, when you check your blood sugar, you have a number. What does that mean? what do I do about that? So there's like, it's just a number, it's just data until, it is provided with context around it. Like, how can you bring it down? How can you elevate it if it's too low? Then, how do you learn from that experience and incorporate it into the rest of your life? So these are some of the themes that flow from what we're doing there. I'm super excited to be in the panel today.
My name is John Hixson. I am also a practicing physician here in the San Francisco Bay Area. I have a number of roles that touch on patient-facing health applications. I primarily treat patients with epilepsy, and I'm a neurologist. So the research side of my life, we just finished a national study looking at the Patients Like Me platform, which will soon be published. So that's one third of my life on the research side. On the clinical side, I spend the vast majority of my time with the Veterans Health Administration, and that's the role by which asked me to speak today. I hold two roles that are pertinent, one locally here in San Francisco, where I serve as one of the lead clinical informaticists. And then nationally, I serve developing applications that are patient-facing for the National VA. And I'll be speaking specifically today a bit about the VA Open Notes project, which, to be fair, I wasn't actually the prime generator of that movement, but I have enough knowledge that I can provide some feedback on that.
Well, why don't we start with that? Because how many people here know about the Open Notes project? One person. There you go. So why don't you tell us a little bit about Open Notes?
Well, that makes me feel more comfortable because it's always intimidating when the audience knows as much about a topic as you do. So Open Notes is essentially what it says, and that is the concept that patients should own their records, not just their lab data and their radiology results and whatnot, but even the notes that the physician or the nurse has written as a method of communicating what's happening with the patient. And this isn't really a new concept. It's a patient's legal right to have access to the notes, but as we all know here, that accessibility is relatively limited just by the barriers of obtaining those records, which is unfortunate. So the Open Notes project was actually not initiated in the VA, although it is now the largest system to have adopted this philosophy and put it into capability. A group in Boston was actually the first that looked at this from a systematic perspective and showed that patients who were given access to the notes felt more informed and engaged in their health and developed a better relationship with their physicians. And perhaps most importantly, that same work showed that the physicians were not as adversely impacted as a lot had feared. In fact, most of the physicians rated that they felt that the use of the Open Notes program enhanced their relationship with their patients. So based on that evidence, there came this push to push VA notes, as it's called, into the VA system. And this wasn't entirely without precedent. So the VA has actually been a proponent of the patient-facing portal since 2000. And that's when this portal called My Healthy Vet was first conceived. It was initially put in a pilot phase for about 3 years and then was fully launched in 2003. And as that program matured, initially it was essentially just a patient-driven portal with really no connection to the internal VA note-taking system. But piece by piece, relatively small bits were added. So initially it was lab values and a lot of the familiar players in terms of a portal. And it was really with the Blue Button initiative in 2010 that this whole trend gained steam and patients were able to go in and quite easily download their records. And I would say that every month after the Blue Button campaign was launched in the VA, some new data element from the electronic record was added to that repository. So in 2013, the notes were essentially opened up. The floodgates were opened essentially. So prior to that, there were many pieces of patient data that were available to the patients through that portal and the Blue Button functionality, but notes were not. When notes were added in 2013, it was essentially everything. Inpatient, outpatient, ER notes, everything. So since that time, there's been a relatively robust acceptance. I can talk specifically about some numbers. There hasn't been 100% penetrance, as you might imagine, and there's a number of reasons for that. But overall, there was a paper just published last fall that recounted the latest data as we have it, mostly qualitative survey data from patients, which essentially mimic what the Boston group had originally showed in their seminal Open Notes project, and that is that patients seem to feel empowered by access to their notes. They're not intimidated. A minority of them actually use those notes to go back and have a, I guess, adversarial, I would say, talk with their physician, because most of them felt that the data that was there helped them, not hurt them. Similarly to the original research that wasn't conducted in the VA, the physicians also reported that they felt that this project helped them to foster a better relationship with their patients, and there have been really very few, if any, adverse instances as a result of the opening of this documentation.
So that's really interesting, and I love this idea of open notes. But of course, the notes are only as good as what actually ends up in the note. And we heard this morning from the keynoter how important kind of social determinants of health are, and who we are as people. You know, information about us as people, how we live, how we eat, who we interact with or don't interact with, and how that impacts our health. So I'm wondering, Manny, from your point of view, do you think, the subtitle of this talk was, patients and data, are we getting it right? Are we getting it right? Do your notes tell, I know you just downloaded your history, so you have recent experience with this. Are your notes telling the Manny Hernandez story? Is that what you want your new doctor to know about you?
Well, the concrete experience you're alluding to actually was basically pressing the proverbial blue button myself. They literally had on the Kaiser portal a blue button image, and I pressed it, and I was checking out to see what they would give me that wouldn't require loads of paperwork and faxes. Those machines that should just be destroyed, but no, it doesn't happen. And I just wanted to see what I could bring over to my new physician, because I was changing health plans, and I was super pleased to discover that it was from a numbers, data, perspective. It was, reasonable. It helped frame the conversation with my new physician to a good degree. It was incomplete as well. I mean, there were aspects about my life as far as elements like, my mother had been diagnosed with Alzheimer's, so certainly that had a phenomenal impact on my health and some of the things that I did or did not do. That wasn't necessarily captured, but it helped, it was a substantial leap forward compared to, say, when I moved from Orlando to California in 2007, and I had to just get things to be mailed and faxed. It was a big difference.
So I think we have gotten better at doing the data. When I moved briefly to Texas, I was able to download, they didn't have the blue button, but I was able to download all my data, and I walked into the new doc I was seeing, and he didn't even look at them. He just said, go down the hall and get all these labs, ordered everything again. So it was still a failure to use. Juliet, what's your take on this? Do you think it would be helpful, for example, if patients had the ability, because docs don't seem to get the social determinant stuff right. What do you think about actually entering that data yourself into your record? Is this something that would be of interest to you?
Yeah, I think that having the ability to give that sort of 360-degree perspective. So even with chronic disease, you're not seeing your physician that often, at least with rheumatoid arthritis. I didn't see my physician that often.
There's a lot of threads in this conversation here, and see if I can touch on some of them. One of them is, Open Notes to me is just a step forward. It's a more enhanced patient portal than the summary patient portals that most EHRs now offer. So it includes chart notes. when I was in training some decades ago, the general sense was you wrote your chart notes, they're yours, and they're prompts to remind you what you talked about last time. And so the audience were other clinicians and other professionals. You didn't really have time to write it in a way that the patient was going to be the audience. With the way that technology has made more transparency, physicians have to be, I wouldn't say hesitation, but you have to realize that the people looking over your shoulder is the person that you're in the room with. It's the patient themselves, as it should be. If you're making comments that you wouldn't want to share with a patient, you're not making the right comments. Personal opinion. The value, the disadvantage of something like Open Notes or any patient portal is that they're still confined to the institution that created the data. So, if you're in a system that uses Open Notes, that's great. Then you go, your health plan changes, or you go see your community doc. I have patients who are veterans that see some specialty clinics at the VA, but they come to see me for the primary care. We don't communicate with each other. They may bring reams of paper with them. But my system and their system don't really talk to each other very well, which is kind of how things have been. The concern is also if you've got a big ream of data, figuratively or literally, how do you interpret that? So what do you make of that? And I think that's a challenge to those who are creating user interfaces and sort of technology experiences to surface the stuff that's important, because interpreting the data is what people want. What do you do with a blood sugar that's 140 this morning? Well, it's in the context, how do you interpret that? My fear had been that the more information that my patients have when they come to me, the conversation is about, so how do I interpret all of this data? And help me put it together. I don't need facts. I can always look up the facts on the internet. But how do you help me make sense out of it all? And what do we do next? Which changes the nature of the discussion with physicians, I think, since I was in training a few decades ago. I think for the better. Transporting data from one place to another, I think we're getting better at. We've still got to have a long ways to go. My belief is that the next generation of health IT data will not be within the EHRs. It will be external and will be universal, and EHRs will interact with that same shared data. And therefore there will be smaller, lightweight sort of workflow enhancements tools that just interact with the data. That's, I think, the next generation. Currently, we've got these big monoliths that have data inside of them, and they don't share data very well. That's kind of why we're building the tools that we're building in Flow Health, is to try to create that platform. But I think it needs to be something that's different than just sharing data, but leaving it in silos. So there's opportunity for better UI, both for patients and for physicians, so that the stuff that comes to mind, you don't miss the things. You don't miss the heart attack that happened 14 years ago that somebody mentions in passing in a record. That's actually there, that persists and is surfaced when you need it. That's not well done by the current technology, but I think we're getting better at it. And the role of the physician is one to help patients interpret the data that's in front of them. And I think that's really a fundamental change in the nature of the physician-patient relationship over the last few decades.
It's actually pretty profound. I'm going to switch gears here a little bit because, you want to make a comment?
Yeah,
Go ahead.
I thought in terms of the, hearing the theme that I think brings forth the concept of the patient as a partner, as a team member, which is, for anyone who lives with a chronic condition, sounds like a given, because just like Juliet mentioned, you have like just a sliver of time, that you have the opportunity to have that one-on-one interaction, and the rest of the time you're on your own. So you by definition, you are, living with it, and you need to be empowered with that. So I think it is very wise that any kind of approach where it's more than just like shifting the top-down approach, but like, really bringing the patient in and making the aspect of the patient experience like central. I thought the concept that you alluded to about like not wanting to tarnish the patient record. Spoke to me perhaps of something that eliminates the notion of like a bad patient. I don't know, that's one to look like we're failing, you know. And in the case of diabetes, I think there's another dimension behind that, which is unfortunately the reality that we deal with every day, which is like the stigma that it carries, all the misinformation and the assumptions that are made, like, oh, you make your way into this kind of thing. So, which is loaded with layers and layers of misinformation, loaded with layers and layers of assumptions. And so the notion that you develop a complication is like a sign of failure. It's like, you know, there'd be so many things that contribute to that, but I think, you know.
You just didn't try hard enough.
Yeah.
Comment. So I hope that not many doctors view patients in a way, and I don't think that they do. But in terms of the data that's within the record, I'll just say for the record that we already know that the data system as it exists currently is horrible and is highly inaccurate based on, you know, copy-paste errors that are just becoming a proliferative problem in current medical records.
But anyway, I'm not sure everybody knows
Oh, sure.
that that's happening.
So copy-paste is copy-paste. So a lot of times you'll have a record where you assume that a lot of the data hasn't changed. And so if the medical record has copy-paste capabilities as a time-saving feature, errors you can easily see become perpetuated over sometimes many, many years. So if a patient has the opportunity to view their own records, they can go in and correct diagnoses that were inappropriately carried over. That is certainly a positive thing, and no physician would ever, you know, begrudge a patient for pointing that out. I would also suggest that in the current medical record, you know, doctors often act like essentially transcriptionists, taking what the patient says and then putting it into the record largely unfiltered and usually based on barriers such as time. So the number one areas I see in this area are family history data, social history data, occupational health history data, which often has a very profound relevance on a person's medical care. And yet those are some of the most often overlooked part of data gathering in a physician's visit, where, you know, it's an average of 12 minutes or something ridiculous like that. Those are the types of data pieces that I think patients, given the opportunity to look at their own record, could actually add a lot of great data to. I mean, if you were a patient who was invested and you were able to look at your family history and not just recollect in 30 seconds what your doctor asked you unprepared in an office visit, but were able to go home and actually talk to your family, then you could actually meaningfully add data there. So the concept that, you know, patient-generated data doesn't belong in the medical record is utterly ridiculous, because just because a physician asks you, what's your family history, and then literally transcribes it into the record, there's not some magical fairy dust that the physician sprinkled over that to now make it medically, you know, relevant information. And so those are the data elements where I think patients really have an opportunity to improve the medical, improve that piece of information for their care.
Great. Well, we have a question from the audience.
It is clear that moving towards a patient-centric electronic medical record is where we're going. I was wondering from the panel, what advice would you have for the clinicians as far as entering diagnoses that are going to ruffle the feathers of the patient when they read it? I'll give you an example. Chronic alcoholism, morbid obesity, drug dependency, personality disorder. How would you react as a patient when you're reading this as an entry in the problems?
Okay, let me just repeat really quickly. The question is, how are you going to deal with entering sensitive kinds of diagnoses like alcoholism or obesity or other kinds of things that may ruffle the feathers of the patient?
I think ruffling the feathers is not what should drive documentation. If there is an entry, and I've run across this, if there's an entry of morbid obesity, and the person is in fact morbidly obese, they're BMI is 48 or something like that, that can be grounds for a good discussion. Here's the criteria for it. Yes, you know, it's a way of challenging denial, because many of these conditions are characterized or wrapped around a lot of denial. And that conversation is a good one to have. So I don't necessarily shy away from, I don't put down opioid dependency as an accusation. It's just, if you're asking for your Norco every month, you've got an issue with opioid dependency, and let's talk about it. What are the plans? Are you going to be on this for the rest of your life until the day you die? Or are you going to, do you have a plan for changing over to something else? So that's a basis for a good conversation. One comment that I wanted to make based on the experience that you had shared about going to another place, bringing your records with you, and having the physician never look at them and say, well, just go do your labs again. That is common. That is, it's a culture particularly in I must say this, in academic medical institutions, that you don't trust the data from outside sources, so repeat it. That is kind of part of training. And I think some of it comes from, if it's not in your system, it's not off to one side, you may not see it, or you just can't trust it, or whatever. That way of approaching, sharing data between physicians is a problem, is one that I think needs to be addressed, and my hope is that with better technology so that the data that they made is in fact the data that's in your system, and you cannot distinguish between your data and their data, and it just looks the same and can be accessed the same. That needs to be there in order to challenge that, but that change is not going to happen immediately, and it won't happen as a result of technology, but technology will enable a culture change that happens in institutions. And I think there's a lot of waste there.
I want to bounce it back to you and ask you, what form would you like it to be in? If you could design the way to do it.
But as somebody who's a little bit more knowledgeable about this, like I know it'd be important to enter like my education level or what my income is, but maybe it'd be better for it to be more leading for somebody who doesn't know, like who's not aware of that. So just simple questions like income level, education level, but it'd also be important maybe to have a space for more like open text, I guess, for the patient to actually have the opportunity to say, this is what I think impacts my health, because that it would be valid information just because their perception is this impacts my health. So it'd be both.
I think you're absolutely right, and it comes with a little bit of both. And on the structured pieces of data, like education, income, and all that, like I think there's an element of like, why do you care? Would be what the patient would wonder, right? Like, what do you want to know? So I think providing enough context to substantiate the need for that, and how would it help, is one. I think the other one just slipped my mind. It was a good idea, I promise.
When it comes back, you just pop
Yes,
it.
I'll say it.
Okay, can I make a comment, please? Yeah.
Sure.
I'm very interested. It's very interesting subject. Sorry, because we are talking about electronic health records, which are really the professional view of your health, which is the doctor, the nurse, and everything. And there's not many personal health records for the moment, but they're coming out. And the future, probably, and that's what our company is working on, is something we call synchronized health record, which is part of the information comes from the doctor, but part comes from you. And in that more global health record, there's going to be sections which only the patient can fit in, because it's obvious that the personal feelings and what you believe you have felt in your body and like some kind of symptoms, they really come from you, and your social things come from you. So we believe that the future synchronized health record will be a combination of the electronic health record from the doctors and the personal health record from the patient. And then very clearly you will see where the information comes from, which is very important, especially for a doctor. If he reads the information, he has to know, does it come from a colleague of mine or does it come from the patient? Because there's other care to be put on that information, of course.
Could you all hear that in the back? Okay. All right.
I just remembered. An example would be like if the interaction becomes you are checking your blood sugar only once a day or only once a week. Why are you not checking? If there's not the why and there's not a trust relationship, you may not even find out that it is because the person has to make a choice, finds him or herself
facing a choice between that and food, between that and, you know, so it's a cost there. So it's like all of a sudden, like it eliminates you combine the income level with like the lack of enough checking, like, you know, there's a lot more context to that.
I also wanted to make a point about patients. So all patients are not the same. All patients are not, do not approach their diagnoses, their care, self-care the same way. Some people are advocates and experts with respect to their own disease. Others are, you know, wanting to be helped along and need a hand-holding. So you have many different types of people. But by and large, what I see when I talk to other patients is they really want to know how to take care of themselves better. And they want to tell doctors what's happening with them emotionally, physically, many different aspects that aren't included in that visit. And I think those are areas where that free-form dialogue can be included. I think when you're talking about social, economic issues, those can be, you know, a one-liner, like what's your education level or something related to that. I don't think people are going to be upset really when you ask those questions. And if you do, that's how you learn and find out whether it's really going to benefit patients and clinicians.
Just to chime in on this, we've mostly been talking about engaging patients with chronic disease around managing their long-term chronic illness. The way I look at it, you know, I mean, patients are people, they're us, it's the population at large, you know, as we interact with the healthcare system. And there's different ways of kind of categorizing different sets of people. I'd like to use kind of 3 different groupings, which are people with chronic disease, and we know those people well in the healthcare system because they're the ones who we see in our offices, and they're the ones who we direct a lot of our outreach and efforts towards. And that is likely to be the most engaged segment of society around this kind of stuff we're talking about, around you know, personal health care and who has control of the record and who's most interested and so forth. Then there are people who are surrogates for other people, like moms taking care of children, or dads taking care of children, or people taking care of elderly, perhaps demented adults. But people taking care of somebody else is another segment of society that is engaged differently. And then there's people who are just sort of young and healthy and only see the doctor when they're acutely ill and want to be seen now when they've got, you know, bronchitis in the fever 105. Or they just went traveling and they come back with diarrhea one way. I mean, acute episodes of care, but otherwise they sort of never interact with the health system. And what tools we build for these different kinds of people are going to be different because the needs are going to be different. You know, it makes sense because a lot of our healthcare dollars are spent on chronic disease management. But not everybody's going to be engaged for that reason.
Exactly. Question?
What's being done to enable the patients to have access to their lab and diagnostic results without getting permission from the doctor?
Well, I can tell you at Kaiser, you go in the morning, in the afternoon, you have an email that links you to your labs before the doc has seen them. So that's Kaiser.
That's good for Kaiser.
Well, that had been, it varied from state to state based on local law for a long time. So some states said that you can't see your own lab records until the doctor signs off on it. Other states said, of course you can see your own thing because the doctor might not get around to it for a while. My belief, and I would have to double check this, that one of the things that hit the final rule of 2013 is that everybody, all states, can see their lab records without a doctor signing off on it. They're just looked at as preliminary. It can be then signed off on once the doctor's had a chance to review them and give you an interpretation about it. Many tools, like what's done at Kaiser, so the EPIC tool, will allow you to see the lab records right away. And I think that's good. I think there's in places, states where the history has been, the legacy has been that no, the doctor has to look at it first. Even though the rules have changed, the culture has to change, and it will take a little while for people to realize that no, in fact, federal rule says that you can share that with patients from the get-go. So there is some change happening.
I mean, I can tell you, maybe this is obvious, but I can tell you why historically it was a problem. is because the records aren't written for patients. So the lab results were never written for patients. They're sometimes barely even written for physicians. Radiology reports were certainly not written for patients. And radiology is an even better example, where there's lots of incidental findings, the vast majority of which are perfectly benign and meaningless to the person's health. And if you were to read that without a physician helping you to interpret it, then you can see how there could be a potential problem. I'm not saying it's right, I'm saying that's the reason historically.
I think you're right, and I think the best example of that is probably when you are tested for something and it comes back negative, and that's actually good. So it's like, it's so counterintuitive, like, if you think of it, but it might take a few years to like really grasp like, oh, this is actually good.
So what's the experience with doctors at Kaiser? Are they upset that the patients get the lab results?
They don't get a choice.
I can't speak for all doctors at Kaiser, but I can tell you, my internist was fully into this is a partnership.
Yeah.
And so she would write me at some point the next day or the day after and say, I went over all your labs, and I said I'd let you know, blah, 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 and, this one we'll keep an eye on, and, so there was no discomfort with it, but that's, an N of one. So I just, Lindsay's had her hand up back there for a while, so
Well, I just wanted to jump in to say that there's some really great new companies that have come up that we've done some consulting with that are doing just this. But more importantly, not only are they making sure people get the lab results, which is already happening, but that they get them with an interface that helps them understand what they need and what to do about them. So there's some really good stuff going on with that.
And I can compliment. I'm coming from Europe. Since 2002, in Europe, there is a law that says that the data about the patient belongs to the patient. So there's absolutely no discussion. The data has to go to the patient. But of course, in some cases, it's problematic. Like if you receive a blood results that shows that you might have cancer and you can detect that, then there's a problem. Then you need to be accompanied by a doctor. And I enjoy your note about emotions, which is very important. And there are some initiatives that in northern countries of Europe, they say that the patient has the right to have the information with a delay of 2 weeks, for example, just to make sure the doctor has the time to read it and interpret and maybe prepare the patient for the results which might be life-changing. So there's all kinds of new programs and initiatives like that, but it's on the way.
My own anecdotal experience in clinical practice, so the EHR that I use will push out to the patient portal the lab results when they're known in the system, but not necessarily when I've signed off on them. And when I sign off on them, I can give the patient an interpretation of everything looks good or your diabetes is at target. But looking at a chem panel or a CBC that might have lots of normals, which are really the things that count, and a couple of calculated lines that the lab throws in there that are abnormal in and of themselves, the patients will come back and ask, what do I do about this? Oh my God, one of the 35 different lab tests are abnormal. And in the context of the other things being normal, that is irrelevant. So it is an interpretation discussion that happens, sometimes by messaging electronically with the patient, which again my EHR facilitates. Sometimes it's a face-to-face discussion. They'll come in with a printout and they'll say, what does this elevated MCHC mean? And we'll have a discussion. It means nothing, because these other things are normal. But it might mean something if these things weren't normal. So that's just, in the context of the other things being normal, that is irrelevant. So it is an interpretation discussion that happens, sometimes by messaging electronically with the patient, which again my EHR facilitates. Sometimes it's a face-to-face discussion. They'll come in with a printout and they'll say, what does this elevated MCHC mean? And we'll have a discussion. It means nothing, because these other things are normal. But it might mean something if these things weren't normal. So that's just...
And I agree entirely with what I interpreted you as saying, which is the opposite case, which is if you have a lab or a radiology finding that comes back that is extremely bad news, right? The whole reason that most physicians, I hope, went into medicine was to establish a true patient-physician relationship so that you could have a discussion about this situation. And you don't want to find out that you have terminal brain cancer from an email that was automatically generated from your hospital. I'm sorry, that's just, why are we doing any of this if that's what this boils down to? So in that particular instance, kind of the opposite of the benign finding, also I would argue mandates that the physician review that first and have a discussion with you.
But it's like trying to be half pregnant, because if you start sharing this information and all of a sudden, oh, I can't give you this test result, then the mind really goes crazy.
Right, that's true. Yeah, that's true.
But I suggested that we might have to change our practice so that if you get that abnormal result, that, you know, we have something that you prioritize right to the top and have that conversation early, not later. And I think we're seeing a lot more of that. I think for Bob and I, when I was initially in practice, I mean, it could take forever to get lab results back. And then, you know, another delay while the physician was trying to find time or, you know, bring the patient in. And now things come back really fast. So we're almost out of time, but and maybe this is like a difficult question to throw out as the last question, but I'm going to do it anyway. Because I used to do a lot of work in the area of domestic violence and spent many years trying to convince physicians, particularly emergency physicians, that they ought to routinely screen women for being victims of domestic violence. And it brings up this issue of the safety of data. And so there's the first question, which is something really, really sensitive, probably more sensitive than saying somebody's morbidly obese or saying that they are an alcoholic, is that they're in an abusive relationship. That's one thing. The second thing is knowing that that data is safe and can't be accessed by someone who could seek retribution that you just disclosed. Any thoughts? We don't need every single one, but anyone within the experience or thoughts on this kind of really super sensitive information?
Well, I would say that that's kind of the core of HIPAA, is to make sure that your data is your data and nobody else sees it without your permission. And when we're building systems that have universal data for a given patient, the patient's at the center of permission giving. And if they're going to give permission to somebody else, they may tell you as part of their social history, I don't want my abusive husband or my abusive partner to see this. No, I don't want you to give them the results of my, maybe she had an abnormal mammogram and doesn't want him to know about it or something like that. So those kinds of comments become part of the person's record, and physicians have to obviously respect that, and patients need to be at the center of permission giving, and we need to build systems that keep that in